Good morning, everybody. Welcome to the California Board of Occupational Therapy Board meeting. Today is February 27. It's 9:33 in the morning. We'll start the meeting. Can we please have a roll call?
Aaron Schweer.
Here.
Virginia Santos.
Here.
Matthew Greco. Louis Arabit.
Here.
Ada Boone Hurl here. Christine Whitlisbach.
Here.
Beata Marcos.
Here, and we have a quorum. Thank you so much. Okay, so agenda number 17, President remarks. I don't have a lot of remarks. I just would like to welcome everybody in attendance. And again, big thank you to DCA for hosting us in this lovely room. We really appreciate it. Number 18, board member remarks. If any board members have any remarks, please. Nope. Vicky? Okay, great. Thank you. Agenda number 19, public comments for items not on the agenda. And this is also a good time for you to come up and introduce yourself if you wish. Yeah, just press the button. There's a gray button for green light.
Okay.
I'm Tiana Hazard. I'm an OTA student at Sacramento City College. That's on, is it? Is it green? It's green. It's green. Oh.
Let's go, I guess, a little closer. Welcome.
Thank you.
Emma Lopez, occupational therapy assistant student at Sacramento City College.
Welcome.
Rochelle Pettit, occupational therapy assistant student at Sac City College.
Welcome as well.
Good morning. My name is Ariana Samaniego. I'm an OTA student at Sac City College.
Good morning, everyone. I'm Selena Aguilar. I'm also an OTAS student at Sac City College.
Good morning. Welcome.
Good morning, Sammy Rafidi, president of the Occupational Therapy Association of California. Good to see you all. Thanks for having us back.
Yeah, thank you for coming back. Is this the cheerleading section for Ada? Just
Practitioners for our future.
amazing. I love that.
Exactly.
Do we have anybody in public that would like to introduce themselves? Is that David, the moderator today?
This is the moderator. Unfortunately, we have myself, Sarah. But I will check on WebEx. For members of the public on WebEx, if you would like to introduce yourself, please click the raise hand icon. Or if you're an audio only participant, you can raise your hand by pressing *3 on your device.
And also if they have any public comments that are not on the agenda.
Yes.
Thank you.
All right. And it appears there are no requests for public comment at this time.
All right, great. Thank you so much. Agenda number 20, presentation from the Office of Human Resources on Executive Officer Evaluation Process. And I would have to hand it over to Catherine, right?
Yes, I am here.
Oh,
Can you hear me
perfect.
okay?
Great.
Are you able to hear me okay?
Yes.
Okay, thank you. Okay, so good morning, everyone. My name is Catherine Bachillier, and I serve as the Appointments and Recruitment Specialist at the Department of Consumer Affairs, Office of Human Resources, also known as OHR. Oh, okay, not sharing my screen.
This is a moderator. Catherine, if you're looking for the share button, it's down at the bottom. Yep, it looks like, there we go. Perfect. Thank you.
Thank you. Okay, my name is Catherine Bachillier, and I serve as the Appointments and Recruitment Specialist at the Department of Consumer Affairs, Office of Human Resources, also known as OHR. Also joining me online today is OHR Section Chief Stephanie Louie. The purpose of today's presentation is to provide board members with an overview of the processes related to Executive Officer annual appraisal process, sometimes referred to as Executive Officer evaluation. Throughout this presentation, the term Executive Officer, or EO, will be used to refer collectively to executive directors and registrars as well. At the conclusion of this presentation, you will be able to have an understanding of the Executive Officer annual appraisal process, identify and understand the roles and responsibilities of the board members and the Office of Human Resources. The annual performance appraisal offers board members and DCA leadership the opportunity to evaluate the executive officer's performance in a fair, impartial, and transparent manner. This process not only reflects on the EO's accomplishments over the past year, but also helps establish clear expectations for the year ahead. The completed appraisal becomes part of the EO's official personnel file and may be included in support of future salary adjustment requests. The process begins when the board president or chair or the EO on their behalf notifies the Office of Human Resources of the upcoming evaluation. This notice should include the date of the publicly held meeting and whether OHR's guidance or attendance is requested. If the board chooses to discuss a potential salary adjustment in conjunction with the EO's appraisal, it is imperative that OHR is noticed at this time. DCA recommends that all boards conduct the annual appraisal between October and December during a publicly noticed meeting. If requested, OHR can meet in advance with the president and EO to review the process and expectations. The board president or chair, EO, or designee, such as the assistant executive officer, will work with the board staff and legal counsel to agendize the executive officer's performance appraisal in closed session and in accordance with the Bagley-Keene Open Meeting Act. Sample language is displayed on the slide. If the board is conducting the evaluation in conjunction with a salary increase request, both discussions can be held in closed session. 1 month prior to the meeting, OHR will email board members with details about the appraisal process and provide the performance appraisal form. The form includes 4 main performance factors, including relationship with the board, execution of board policy, administrative functions, and public liaison, each with subfactors. Board members are expected to independently evaluate the EO using the form and be prepared to discuss all 4 factors during closed session at a scheduled board meeting. Board members must email their completed appraisal form directly to the board president or chair prior to the meeting. This allows time to consolidate feedback onto a single final appraisal. Please do not share your completed form with other board members. 1 week prior to the meeting, a reminder will be sent to the board members by OHR. During the public meeting in closed session, the president or chair will lead the discussion, reviewing each of the 4 performance factors. Board members will share their comments and work towards a consensus on final ratings. The president or chair will also present commentary from DCA's executive leadership. If the board chose to discuss a potential salary adjustment in conjunction with the EO's appraisal, this will be discussed after the evaluation and after consultation with OHR. A separate presentation is available to review the EO salary adjustment process. After the public meeting, the president or chair will finalize the consolidated appraisal form and meet with the EO for issuance. Once the board president or chair reviews the appraisal with the executive officer, both will sign the document and forward it to OHR for placement in the executive officer's personnel file. The performance appraisal form includes a dedicated section for comments from DCA's executive leadership. This commentary may include feedback from various DC divisions that have worked with the EO throughout the year. This takes into consideration the executive officer's requirement in matters such as, but not limited to, keeping DCA's executive office informed of key issues and accomplishments related to board operations, maintaining positive and respectful partnerships with the board staff, DCA, and other DCA boards and bureaus, complying with mandates from the administration, agency, DCA, and control agencies, responding to all inquiries and requests timely and tactfully, and conforming to existing rules and regulations, and collaborates with DCA's regulation unit effectively. To allow sufficient time for this input to be gathered and incorporated, it is essential that OHR is notified of upcoming evaluations in a timely manner. The DCA executive leadership feedback will be provided to the board president or chair prior to the board meeting. During closed session, these comments will be shared with all board members as a part of the overall evaluation discussion. Thank you for your time and attention today. To summarize, we've covered the annual performance appraisal process and identified the roles and responsibilities of the board members and the Office of Human Resources. Now I'd like to open up the floor to any questions. Thank you. Do we have any questions?
Oh. No?
No questions?
No questions.
Sounds great. We can move on to the salary and salary increase process as well.
Great, thank you.
Thank you. Okay, so the purpose of today's presentation is to provide board members with an overview of the processes related to the executive officer's salary and level increases. Throughout this presentation, the term executive officer or EO will be used to refer collectively to executive directors and registrars as well. At the conclusion of this presentation, you will be able to distinguish between salary and level increase requests and understand when one may be more appropriate than the other, understand your role and responsibilities in the salary and/or level increase processes, identify key factors that may justify a salary and/or level increase, and understand the steps involved in the review and approval of these requests. These objectives will help ensure you are well prepared the next time the board considers a salary and/or level increase for the EO. Before I go over the different types of salary increase requests for the EO, I want to provide some background information first. EOs are considered exempt employees because they are appointed to positions that are not subject to civil service law and rules. Unlike employees in civil service classifications, such as Supervisor 2, merit-based salary increases are not automatic for exempt employees, even if the EO is not currently at the top of the salary range of their exempt level. Any salary or level increase for an EO must be formally requested and approved by the board. Additionally, exempt position levels are established by CalHR. As noted in the final bullet on the slide, the California Department of Human Resources, or CalHR, is the ultimate authority for approving any salary or level increases for exempt positions. I will provide more details on this process on the following slides. So there are two types of requests that may affect the EO's salary. The more common of the two is an exempt salary increase request. This type of request applies when the EO is not yet at the maximum of their current salary range. In this case, the board may vote to approve a salary increase, typically between 2 and 5%, as long as the new salary does not exceed the position's salary range maximum. The increase must also be effective no sooner than 12 months from the EO's last salary increase. While the board does have the discretion to approve a salary increase greater than 5%, as long as it remains within the current salary range, it is important to note that CalHR may delay its review of such requests. It is not uncommon for CalHR to request additional justification and, in some cases, reduce the proposed increase to a more reasonable amount. This can result in delays with the final approval and result in a later effective date. To avoid unnecessary delays, salary increase requests should align with CalHR's established parameters whenever possible. As noted earlier, CalHR has final approval authority. The second type of request is known as an exempt level increase. As mentioned earlier, each EO position is assigned to an exempt level, which corresponds to a specific salary range. Salary levels are listed in ascending alphabetical order, with higher salaries associated with earlier letters and lower salaries with the later letters. Please note that there is an overlap in salary ranges across the levels. If there has been significant growth or change in the board's structure, responsibilities, or workload since the last level change, it may be appropriate to request an exempt level increase for the position. It is important to understand that a level change affects the position itself and not automatically result in a salary increase for the current EO. I'll illustrate this distinction further by discussing a few different scenarios in the upcoming slides. This first scenario illustrates an EO whose current salary is on the lower end of the salary range for a level O exempt position. If the board requests a 3% salary increase and CalHR approves it, the new salary will remain within the established salary range, leaving room for potential future increases. In scenario 2, if the board votes only to increase the exempt level of the position and is justified, a salary increase for the EO is not automatic. As shown, the salary range for level O and N overlap. While the level increase expands the position's salary range, the EO's current salary of $9,902 will remain unchanged unless the board also requests and approves a separate salary increase within the new level. This will be further illustrated on the next slide. So similar to scenario 2, in scenario 3, the board voted to approve a level increase for the position. However, this time, they also approved a 3% salary increase for the EO. If CalHR approves the request, the EO's new salary will be $10,199, which falls within the new salary range. Since the new salary of the EO is still within the new salary range of exempt level N, the board may request another salary increase after 12 months. You may be wondering which option the board should pursue. Rest assured, OHR is here to assist you every step of the way. If the board is considering a salary and/or level increase for its EO and position, we ask that the board president contact OHR to obtain the EO's current salary and other relevant information. Alternatively, at the board president's request, the EO may also reach out directly to OHR. We recommend a meeting between the board president, EO, and OHR prior to a decision being made. This meeting provides an opportunity for the board president and EO to ask questions and receive clarification, particularly if this is the first time a salary increase proposal is being pursued for the EO. Upon initial contact and during the meeting, OHR will provide the information showed on the slide to both the board president and the EO. To maintain transparency, OHR will include the EO in all communications and meeting invitations with the board president. I will explain the reasons for this shortly. The information provided will help the board president determine which option to pursue. For example, if the EO's current salary is 2% below the maximum salary of the exempt position, the board president will know to recommend a 2% salary increase during the EO's annual evaluation conducted in closed session during a board meeting. In another scenario, if the last level increase occurred 7 years ago, the EO has been at the maximum salary for 4 years, and the board has experienced significant growth, it may be appropriate to pursue both a level and salary increase for the EO and the exempt position during a board meeting in open session. Once it has been determined when the salary and/or level increase discussion will take place, the board will agendize these items for a future scheduled meeting. Typically, the EO or board staff coordinates these efforts, which is why the EO is included in the discussions to keep them informed and allow adequate time to prepare. Please note that if the level increase discussion occurs during open session, OHR can attend to explain the process and answer any related questions. If the salary increase discussion takes place during closed session as part of the board's EO annual evaluation, OHR will also attend to provide guidance on the process, respond to questions, and document the board's approval. A separate presentation is available to review the EO annual evaluation process. Attendance of board council in closed session is not required, but may occur at the board president's request. If the board plans to discuss and approve an exempt level increase for the EO position during open session, it is standard practice for the board president, working with the EO and board staff, to draft a written justification for the board's review. The justification should explain key changes or circumstances that support the proposed level increase. It should also clearly state the recommended exempt level and salary adjustment for the EO. Including this justification in the meeting agenda materials will help facilitate a more informed and streamlined discussion during the board meeting. Additionally, much of the information in this justification can be repurposed for the formal request to OHR, which I will cover shortly. While a justification to the board is not required, it is strongly recommended that the board president prepare speaking notes or a bulleted list outlining the key reasons for pursuing a level and/or salary increase for the position and EO. These supporting documents can be developed with assistance from the EO or board staff, and it will help ensure the rationale is clearly communicated during the discussion. As mentioned earlier, any request for a salary and/or level increase must be supported with substantiating data. The board president, with assistance from the EO and board staff, is responsible for documenting the changes that justify the increase in a formal justification submitted to OHR. As noted earlier, the board president can use the same information used from the board member's justification if one was completed in the justification to OHR. Additionally, the board president may include any further evidence that strengthens the case for the increased request. If the board is pursuing only a salary increase for the EO, the justification should focus on new information since the last salary adjustment. Emphasis should be placed on an increase of duties and responsibilities, accomplishments, and examples of exemplary work performance. These are just a few examples. Any quantifiable or notable achievements may strengthen the request. If the board is pursuing a level increase for the EO, the justification should focus on items such as organizational growth, expansion of responsibilities, and any significant increases in staffing, just to name a few. However, an increase in staffing levels alone is not sufficient to request a level change. If there is no specific deadline to submit the justification to OHR. However, once the finalized justification is received, OHR can begin preparing and submitting the required documentation for review and approval. If the board is requesting both the salary and level increase, a single combined justification may be submitted. As noted earlier, a meeting between the board president, EO, and OHR is strongly recommended as it provides an opportunity to discuss the request in more detail and determine what information should be included. For your awareness, OHR is responsible for preparing what is known as the exempt position request or EPR package. The documents that comprise the EPR package are listed on the screen. Once OHR receives the board's justification, we will prepare all the documents and submit them for approval. Please note that the proposed effective date for any approved increase is typically set for 30 days after OHR submits the EPR package to the Business, Consumer Services, and Housing Agency, also known as agency. Once OHR has prepared the EPR package, it is forwarded to DCA Director for review and signature. The Director's signature indicates a recommendation for approval of the request. The EPR package is then sent to agency for their review and approval. The board president and EO will be notified once the package has been submitted to agency. After agency's review, the EPR package is forwarded to the governor's office and CalHR for further review. As a reminder, CalHR is the final approving authority to approve, modify, or deny the request. Upon approval by CalHR, the director will notify the board president and EO. OHR will then process the salary increase and notify the EO once the pay adjustment has been issued. If the EPR package is not approved at any point, both the board president and EO will be notified accordingly. A common question is, how long does it take to find out if a salary or level increase request has been approved? Well, review times can vary, but generally, agencies' review takes about 30 days, followed by an additional 30 days for CalHR's review. If the justification lacks compelling information or repeats details from a previous request, CalHR's review process may take longer. So thank you for all your time and attention today. To summarize, we've covered the differences between salary and exempt level increases and when one request may be more appropriate than the other. I'm confident this information will help guide your decision moving forward. I'd now like to open the floor to any questions.
So I just want some clarification. So for the EOs, they don't get any increases, no cost of living adjustments, only through this process. Is that correct?
They do get cost of living adjustments.
Okay, how does that work and when does that occur?
Cost of living adjustments are typically around July.
Every year?
And then yeah, I'm sorry, what was that?
Every year?
Well, based on bargaining unit contracts, they may or may not
Gotcha.
get one every single year.
Okay. Thank you.
You're welcome. Any other questions at this time?
How often is the performance appraisal of the executive officer?
Yearly.
Thank you.
You're welcome.
No other questions? No? Well, thank you so much for your presentation, Catherine, and Stephanie for your support as well. We really appreciate it. It was a lot of information, so I might want that
It
slide
was
back.
a lot of information. Well, thank you guys. Have a good day.
Thank you. We'll be in touch.
Okay.
Have a
Thank
great
you.
weekend.
You
Thank
too.
you. Thank you
Okay.
so much. Bye.
Bye.
Comment.
Mhm. Uh, Do we have any board discussion here regarding this? And then I'll go. Do we have any public comments? Can we please open it up on the WebEx for public comments?
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click that raise hand icon, or if you're an audio only participant, you can raise your hand by pressing *3 on your device. All right, it appears there are no requests for public comment at this time.
Thank you so much, moderator. Okay, we're moving on to agenda number 21, a presentation from Tammy Richmond with amazing titles on artificial intelligence in healthcare. Do we have Tammy on WebEx?
All right, this is the moderator. I promoted Tammy up to a panelist just now. Give her one moment to unmute herself.
Good morning. Can you hear me?
Yes, we can. Good morning.
Okay, thank you. All right, I haven't used this software for a while, so am I allowed to just simply share and then bring up the slideshow?
This is the moderator. Yes, you should be able to. If you see the share button down at the bottom, if you click that, that'll give you the ability to share an application or share your screen.
Okay. Um, Hang on. Let's try this again. Do you see
Perfect. And we
my
can, yep.
slideshow? Okay. I can't see you if I push the whole screen. Is that correct?
That is correct. You won't be able to see the WebEx.
Okay, so for my audience, would you like me to be able to see, or do you want me to go ahead and go in full screen into full slideshow, or does it matter?
Full screen, please.
Okay, so for some of you who don't know me, and of course I can't really see you either now, my name is Tammy Richmond. I approached the board back in the beginning of, and thank you for allowing me to have these moments for you, with you. I approached the board back in November because I was aware of AB 489 passing. And I was watching this bill very carefully for multiple reasons. And one of it is because of the position that I have, both as an occupational therapist and as the chair of the American Telemedicine Telerehabilitation Special Interest Group at ATA. I also recently chaired the Digital and Telehealth Task Force Group at ACRM, and I have authored multiple publications in the past. I was at this board previously back in 2010 at a very vital time when I was promoting telehealth at a national level with colleagues. And at the time, we were concerned about where we would be positioning ourselves if and ever we moved into telehealth. And of course, fast forward into COVID, it's exactly what happened. And all of us had our first, sometimes some of us had our first experiences with telehealth. As far as myself, I've been working in telehealth since 2008. I'm here because I'm talking about artificial intelligence, and artificial intelligence is not telehealth. There is a distinct difference, and I want to talk about that today and how it fits in with AB 489 and why I'm concerned. I'm concerned also because I've been able to sit in several meetings over the last 8 months that allow me to hear conversations I wouldn't probably normally hear, and they affect our professions. And so right now I'm here because 489 begins to protect our healthcare profession because we are under siege. Our status as reimbursable providers is under siege. Our tuition to support our students is at risk. And this is part of a bigger plan, which includes why we need to protect our profession from artificial intelligence. So right now we are being encroached by corporate owned and sponsored monies and a federal administration that will support them. And when we're not at the table, we are on the menu, and that's about what is happening for us. So I don't want to be an alarmist, but I want us to use this opportunity, if we can, to discuss more about what 489 can and should be used as a platform of us at occupational therapy to look at the future of where we're going to be when we look at new tech-enabled devices and products. So what I won't be covering today, because we're going to be out of time, is I've been in this space for quite a while. When I created my own telerehab portal, I wrote algorithms with my tech team using large language data sets that we created. It was a natural climb to move into AI because it became easier to program to get the software systems in. And that's what brought us to today. Obviously, 489 was based on the unfortunate result of a young person taking their life, who he thought he was getting advice from a human with a healthcare license. And so I applaud Gavin Newsom in stepping up and looking at this as a larger whole to a problem that is going to be systemic. I just thought I'd give a really quick view of AI and terminology in healthcare. I've been talking about this topic for 2 years under ATA. I can share with you what I know so far and where and when AI is being currently integrated in OT. Part of ACRM is research. And when I've been there, I've looked at a lot of the new tools coming out. I've interacted with people creating tools. They'll often use the term human design, human-centered design, when they're talking about keeping us in the loop. And that's only on the design phase, but it's not on the outcome phase. I will share with you some quick benefits and core issues with AI, quickly go over the mapping, and share with you again why this is important. I am here because I support your goals, which is to protect the consumer. right? To ensure that we have ethical, transparent, and lawful use of AI. Since AI is not telehealth, and there will be agencies that tell you it is, it doesn't work the same. Telehealth was a conduit of communication tools. AI is a system, right? It's a software system using algorithms and bias information of which to build upon lots of other things. So I'm here because I don't want to be misrepresented. I don't want OT to be misrepresented in software coming out. I want us to align with the standards of practice. And I think we're down to being able to demonstrate our value to the consumer's quality of health and life and our own profession. There is lots of research that supports all of where we see AI going in OT, both in the complete transformation of our education, administration, and our clinical services. I'm not going to be able to talk about all of these three areas. I'm going to talk to you mainly about the clinical side of what I see going on and how that affects us going forward in regards to AB 489. From the federal side, this is how AI is defined. It makes decisions, makes recommendations, and it makes predictions on human-defined objectives. HHS, the federal agencies in healthcare, and this administration feel totally convinced that AI is AI in healthcare is where we need to go to improve treatment and patient outcomes, to reduce the burden, and also for us to be more efficient. I can tell you that they see allied health professions as low-hanging fruit. When you look at an ROI from the standpoint of a hospital system, we don't make money for them. Sometimes we're break even. And because of that, there is this concern I have that the new AI that's coming out will replace parts of what we do if we're not careful, which is why I think 489 is so important. There are two types of AI commonly found in OT. One is called generative AI, which is basically your chatbot. We see this a lot already in our EMRs. People and students using it to do treatment planning, innovation strategies, a lot of our back-end administrative tasks. Predictive AI is something I actually wrote within my own company, where we take patterns and trends and we sort of allow that to forecast, in my case, injuries to workers before they actually happen based on the algorithms that we created. We see this being used very successfully in early detection of cancers and other high-risk potential impairments. Again, we do have a really good example of a predictive AI being used in OT, and I will share that with you in a minute. How does AI work? Well, we know that because chatbots are all around us, right? In our devices, our phone, our hard drives. You can see AI everywhere. Our systems, Google's, Microsoft, I'm on Microsoft, they will automatically add in more AI and AI without asking for our permission. And they're not even transparent. We don't even know it's showing up. It just shows up every single day when we're here. That is also happening in healthcare. So you need hardware and software. That's it. And an AI system in the background. Copilot, Claude, you name it, ChatGPT, that's all those companies. It takes data that has been uploaded, lots and lots of large data, and it spits out whatever you need it to do by prompting it, right? Programming AI, however, is based on that a learning. It's learning from what we put in it. A reasoning, like how is it reasoning with the materials we're giving it? How does it come back with something that may be useful based on what we're giving it? Self-correction, and the tricky part now is creativity. Right? In the perfect world of AI, and the inventor started it decades ago, was that it would be human-like. These are the two main buckets of where we see AI now, and it's easy to see where it fit in administration. I use it in documentation. I use it for scheduling. I use it for reporting. I even use it for communicating, right? I feel comfortable using that. I also can tell you that I review all the materials because AI is biased and it makes mistakes. It has hallucinations. Right? On the clinical side, we're beginning to see the innovation and the installment and the integration of AI in our assessments, intervention planning, remote monitoring, which is the area I come from, personalized feedback, and outcome predictions. This is the area of which 489 was looking at, where we don't want AI to be providing services that look like and sound like occupational therapy, but they're not. They're not us. There is no human in the loop. My colleagues and I, 3 other colleagues and myself, with the sponsorship of the World Federation of OT, did a survey around the world last fall. we got the survey back. We came through these conclusions, of which will go to publication in April. So I wanted to know really how many OTs are really doing AI, how many people know about it, how we are curious around the world. Do we need to write standards and guidelines through the WFOT, let alone on our own AOTA and now here in California? Again, this makes sense. The most common applications are on the administrative side. The least common application so far, which is good, is on the assessment and intervention delivery, and very little on remote monitoring. And that's important, and I'll tell you about that more in a second. So here are the benefits, right? Real-time data. In my business here in Los Angeles, I own Go to Care, which is a hybrid telehealth company. We provide in-person and online services. When I'm collecting real-time data from a remote monitoring software, I can see what my patients are doing and not doing every time they interact and engage with the app. It gives me time. I can make it give me all different parts of data, right? So that's important for me. So when I see my patient 2 days from now, 3 days, I'm not just reliant on their narrative. I can really actually see what they did and did not do. I am reliant on their narrative to see how it translated into performances across their activities of daily life, but I know I know their data. It's certainly helping us in documentation assistance. I don't know that it saves time, but it certainly makes it easier, right? We're beginning to see evaluation and intervention tools where the scoring is very easy. Interventions are suggested, and that's the part where we need to be careful. And then the whole idea behind AI and tech-enabled products and services was to motivate the client. So even during the Obama administration, he wrote the initiatives of the Affordable Care Act, and one was to keep the client engaged, being proactive in their health. And they were hoping at the time, and that was the beginning of development of apps, that apps would keep people in charge of their health. But we have yet to see on an average basis that patients will stay with their program after they're discharged, even a wellness program, for more than 8 weeks. So therefore, we lose the overall benefit of what they came to see unless there was some complete recovery of why they were in an occupational therapy. Where are we going? Why did I come to you today? Why am I so concerned? Because we have what's coming next called agentic AI. It is an advanced form of artificial intelligence that's already here. It can do complete complex tasks across multiple systems, and you wouldn't know it. And unlike traditional AI, it makes decisions, it uses tools as it wants, it performs sequences, and there's no human involved. This has been driven just because that's how engineering works, right? We're capable of doing it. The innovators like to innovate. There's tons, billions of dollars behind this innovation, and it's in healthcare, right? It's shifting my passive data analysis to completely closing that loop. So as the AI agent works, it doesn't need me to modify treatment plans. It will learn from the patient it's working with, right? And so driving the shift is wearable sensors, brain computer interfaces, which you see a lot of, and again, these generative AIs, which we're already working with. So as you may have noticed that when you're in your chat GPT, it records now on your left-hand margin every conversation you're having, and it will remember what you asked it every single time unless you remove the history. It begins to learn you, right? And your habits and the type of questions you ask. This is the beginning of what an AI agent can do. It observes, it thinks, it decides, and it will act without you. And this is why, if we're not careful, we will be left out of the loop completely. So 489 gives us a chance to look at what we don't want AI to do, right? We don't, in my opinion, we don't want it to diagnose. We don't want to set goals without our clinical oversight. We don't want it to override our judgment. And we want to make safety critical decisions alone. I say that because how it is appearing already is that it will progress patients without us there. So how and what are the names that you're going to find it where and being used in OT? And this is one of them called digital therapeutics. So a year ago, American Telemedicine Association merged with digital therapeutics. At first, I didn't know what was going on. I've been a part of ATA since 2008. That gives me almost 20 years of being in telehealth. ATA is an organization thought to be the godfather of all things telehealth and telemedicine, and now they're taking on AI. Digital therapeutics is a named software that's intended to treat or alleviate a disease, disorder, condition, or injury. It can diagnose. It does not have any billing codes yet. So therefore, it's going to comfortably use ours. I'll talk about that in a minute. It works in a variety of ways. If you go to this website, you'll see all the companies who are already calling themselves digital therapeutics. When ATA purchased Digital Therapeutics Alliance, I was not quite sure how it was going to fit in the framework of what we do at ATA, which has mainly become a VIP lobbying alliance to CMS and the federal government in healthcare. So I began to do a little more networking and understanding as my position and then as a fellow at ATA to understand where AI may pop up and already is for us. So in these four categories, in data analysis, robotic assistance, predictive analytics, and remote monitoring. The problem with that is that when AI acts alone, without a human in the loop, we don't know who owns the data. We cannot forecast patient safety. We don't have clinical accuracy. AI cannot explain why it does something. It just gives you the what, right? It does the how. We are concerned that it has no ethics or governance because the federal government doesn't want to govern it under this administration. So therefore, there's a lack of accountability and a liability from the main agencies that should be protecting our consumer, which is the CMS and the FDA. But that's not going to happen. So it's biased already, as it is with large language groups. It's functionally unequal. It underscores the important information we have around seniors, minorities, people of color, and different cultures, right? People who have challenges. Large language databases don't often include information about those folks, those kind of consumers. What that does to our profession, when we use AI and we get too comfortable with AI, which is already happening, it erodes our ability to create a therapeutic alliance and trust with our patient because we have something between us now. We have an agent, someone who could be as smart as us or smarter, right? And I find already that when I'm getting emails from educators and students, they're concerned that they may already be over-reliant on using ChatGPT or other parts of AI in their learning. So how do we preserve the important parts, our value of what we bring to the table? In our worldwide survey, we also asked people around the world, we had 81 countries respond, almost 900 participants responded. They had the same concerns that we were hoping, right? That they're concerned about the critical thinking, the data, the ethics, the evidence for even using it, the liability, and are we even ready for it because there is no regulatory language written anywhere in OT around AI. Conveniently, because most people like to think it's telehealth, and I was here spearheading telehealth many years ago, and it is not telehealth. It is software as a system. So we are being encroached upon by software. I threw this slide in, it wasn't in your original deck because I've been giving this talk all week and there was an ask around evidence, right? I think the important part is you skip to the column on your right to understand where AI lacks, where it's limited. It's even limited in this as an agent, right? This is where we have the strength. And we need to recognize that. And as we look at 489 and you begin to develop concepts and language around that, I think it's going to be very important to understand what we do and what AI cannot do, right? And what we don't want it to do as it innovates within this agent AI upcoming version, I guess is the way to say it. So we have a lot of innovation in OT. I've seen a lot of these pieces up close and personal. I interview a lot of these companies because I like them to be guest speakers of my ATA membership meetings once a month. I've looked at multiple smart wearables, robotic rehab, AI-powered vision, telehealth platform, diagnostic platforms, smart home, and aging. These are all areas of which OT works in, and these are all areas where AI is already being evolved. Oops, wrong way. Some examples. So I suggested to you that we already have a predictive AI company out there, and this is it, Kuro AI. It's capturing video, it's making decisions about the behavior of the child that it's capturing. Do I think it works? Do I think it's reliable? I have no idea. I haven't had a chance to meet with this company, but I know it has OTs that worked in the back end of the concept, right? So this is where we're at, where companies are coming out, they're promoting OT, but we don't know enough about the back end of the OT to know whether or not it's jeopardizing our professional standards. The company on the right is a fall risk company. They make a new software. They have received more monies. I've met with this company. I do think it's valuable to prevent falls at home. But again, as we begin to go forward, how do we vet out all these new apps coming forward? How do we know that they're not going to act like human and accidentally give out advice as AB 489 is talking about and act as OT without us being in the loop? There are some other areas of which we're seeing AI move into. I don't want to bore you with any of this. Again, anything and everything that we do, the tools in our clinical wheelhouse are going to be affected by the integration of AI. This is an area I'm bringing up because this is the area where AI is already working and is already providing input without the human. So remote therapeutic monitoring is not telehealth by CMS. It is a separate set of codes that we got 2 years ago. We're in our 3rd year now. It allows our digital home program, exercise program. It went to digital, now it's on an app, and this app, if it is used a certain way and created a certain way, fits the definition of remote therapeutic monitoring. This came about because we are not on the provider list for remote patient monitoring. And all of the systems wanted a way to monitor patients at home that weren't vital signs. So a couple years ago, RTM passed. It included musculoskeletal dysfunction, cognitive dysfunction, respiratory dysfunction. They threw in pain, and we expect that to expand very rapidly. Why? Because CMS could come up and make up new codes right away, because they fell out of the umbrella of the waivers that we're in under telehealth, the waivers that we're still in, right? Until the December 31st of 2027. So they have these codes. These codes allow physicians and us, non-physicians, to go ahead and bill insurance companies and CMS for services that the home digital program. AI has the capability of going in here, once you upload the patient, it goes in here, you put together a program, it will tell the patient what they're doing wrong. It can also progress the patient if you aren't telling the software company that you need to make the final decision. That software is already in existence. Where you see all these asterisks are already companies where AI is in it, and OTs and PTs are using it. And they're not always aware of the fact that AI can and will be working in the background and leave them out. So where is the policy where we're at now? Well, I'm sharing with you this. There is a reason why CMS and FDA created the RTM and RPM codes. They needed another way to code the AI or the digital therapeutics because there weren't other codes assigned to them. If we use AI in our assessments, I'm assuming we could probably use our CPT codes, but that's not clear. So RTM codes give a way to bill for AI, and so they just slip it underneath the radar, right? So, and because it's not just us using the RTM codes, physicians can use the RTM codes, they can do what we do. They just revised the codes and added more codes, not for us, really, right? For the hospitals and for the physicians. Why? Because now you only need 2 days of data. Now you only need only 10 minutes of jumping online with the patient, or audio only, which is only on the phone. So what happens with 489 already is 489 is just trying to curtail what AI can do as far as its language, talking to a patient or to a consumer, right? In our regards. There's a bigger underlying problem here, that we're going to be left out of the loop if we don't use 489 as a platform to look at other things happening in the state of California. What we do know about RTM, and I'm going to stay there, is because this is where AI is going to go first, and it's the easiest place to put it because it's going to get paid for, is that we are typically not the people using it. We're only 4%. So the hospitals need a bigger ROI. They don't see OTs and PTs as a benefit to their ROI. So what are they going to do? They're going to let the doctors give out these apps with AI in it as an active agent, right? Because they can use the RTM codes to get paid. How is the consumer protected? Right now, there are no regulatory languages. What came out in the fall with Gavin Newsom was something that was so exciting to me because we're one now of 34 states trying to build AI regulatory language. We need it for the safety of our consumer. We need it to protect our consumer and our profession. The federal AI laws are no longer existent. Under the previous President Biden, we did have a general degree, I guess, to create that they had to come to Congress when requested, all these big companies, and talk about AI. This president got rid of it. There's no single comprehensive federal law. However, HIPAA still applies to us. The FTC Act still applies to us. FDA oversight applies to us, but FDA is changing under our new leadership. Right now, there are 34 states that have AI legislation. I know a little bit about Illinois. We are the first state where OT is having to look at AI. And so I'm here because our model language, like we were in telehealth, when I came to you, the board, in telehealth in 2010, we were the first state. Your model language created the platform of which brought us to the table and ready to work when we had COVID, because your model language set the tone for the rest of the country. We are at that place now, which I believe is very important, where we need to look at and set aside time to look at what all the other states are doing. How can you, the board, protect the consumer here in California and establish some model language or activity around AI? Because if we don't do that, we are going to lose ourselves to organizations with a lot of monies behind them that are profiting over and wanting to profit, having hospitals use software that leaves us out of the loop. So prior to the 3 bills that passed, including 489, Gavin Newsom did pass the Privacy Act and the Privacy Protection Act, which was about profiling. So we can't use this information to harm people, right? He went a step further in 489 to say you can't have the software pretending to be a licensed healthcare, person. So I'm here because I'm concerned that harm will and can take place, right? I'm asking maybe the board to put together an ad hoc committee so we could begin to look at what elements of protecting the consumer and our standard of practice could be affected by AI. Is it a low risk in a certain area of practice? Is it a high risk? Where does it fall under our modalities? Where does it fall under telehealth? What parts of what we do should never be automated? What parts do we want to keep human? What parts do we keep human because it protects the consumer, because we have the last voice in what happens next, right? We have to create a perfect balance of AI and innovation along with safety and connection and trust with our patients. And so what governance is needed? This is an opportunity for us to really look at that. And I'm here to ask the board to take a big look at that. And then how do we keep ourselves in the loop? Because like I said in the beginning slide, when we're not at the table, we're on the menu. And I'm afraid we're getting really close to being on the menu. And so if you have any questions for me, I'd be happy to take them. And if there's, I know I talked really, really fast. I was only given 30 minutes. And I wanted to be respectful to that.
Okay. Are we, can you see us, Tammy? Or no?
Yes. Yes.
Okay. Hi. So thank you for coming today. And I enjoyed your presentation. I don't know a lot about this, but I do know that you are the expert in this area, as you were in telehealth, and you were way ahead of your time there. And thank you for all your work with that, by the way. I'm just wondering, I understand most of your presentations, and I'm just going to admit that I don't understand everything, but I was wondering, it's obvious that this is something important that we should address. So I'm convinced about that. So thank you for bringing it to our attention. But what I'm wondering, if you could give just a couple examples, and I know you don't know exactly where this is going to go, but a couple examples of what your fear is, like in real time. Like, I'm afraid that they're going to use this technology and this is what it's going to look like. Just give some examples, like for a clinician who Just trying to understand what your concerns are.
Well, my first concern is that non-allied health, including OTs, will be using AI to perform occupational therapy. When they get to places where we have a staff shortage, right? So telehealth was about access, right? But still in this country, only 13% of all occupational therapists even use telehealth. So we keep giving up our patients to people who are available. And so here now, the doctors and the hospital systems have a way to provide parts of what we do without them sending the referral to us. So part of the legacy of the Kennedy at CMS and FDA is that he wants food as medicine. And I'm sitting on a committee now looking at this. They are inventing new wellness codes. They're going to use AI, the same agentic AI I just shared with you. They didn't have us at the table. They had dietitians. We're not on that prescription. We're not on that list of providers. I raised my hand and said, we have a lot of OTs that work in a sensory diet. So why would you want to leave out the OT who's working with the child whose some of the goals are to working on their sensory diet for their challenges, right? That was the first they ever heard of that. And so I'm sharing with you, I'm concerned because we can't be everywhere, right? But yet all of these systems are looking for a way to treat the patient at the time of the doctor visit because they can add on an extra $126 in that one visit in order to give that app to that patient, that parent without us there. It's all about money. And so for the clinician who's not paying attention, what the system is set up to do now, and I'm acting as an alarmist because I've sat through these meetings, they only want us to see the complicated patient. They want apps and software to do everything else that is the low-hanging fruit. They're categorizing this as wellness, and you're going to see more of this. So there's a new program called MAHA, Make America Healthy Again. Under that, we're going to be services that I feel we do, that it's in the OT's wheelhouse, unless we give it up, right? And so I'm giving you one example. In my case, I work in adult phys dis. So what will happen when a patient goes in to see their doctor on a follow-up for a IC total shoulder replacements? They'll go and total knees and total hips in the orthopedic realm. When a patient goes in and has surgery with the doctor, that doctor can easily now give them one of these apps that already has the prescribed clinical program in there, the protocol program for total hips, total knees, total shoulders. That patient can go home and the doctor can say, just follow these exercises, right? This is what you'll do. And the AI, the software will tell you when you should advance the next exercise. That already happens. I'm not in the loop, right? The PT isn't in the loop. They're not addressing ADLs. They're not addressing other things like the skin and the swelling. It's just an exercise program. The doctors are doing it because they can use these codes and garnish $126 a month. And that doesn't sound like a lot, but when you take $126 and multiply it by thousands and thousands of patients, it's a moneymaker.
Yeah, thank you. That's helpful. Thank you. Can we bring Tammy up on the full screen so we can see her better? Or maybe that's up to you, Tammy, to minimize.
Oh, I don't know if
there.
I don't know how that
That's
works.
much better. Yeah, that's perfect. 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 Thank you.
Ada, you have some questions?
I thank you so much for being here today with this conversation. In my practice area currently is in education, and we're struggling just in how to find that right balance but know that we need to teach future practitioners in the moment now. And so I'm just at the point of trying to organize what it is and how we teach at the educational level. But I completely hear the alarming concern and understand that it's almost that we are not act now. We're too late in a way is what it feels like, in a sense of urgency to me. So I very much appreciate this conversation. There were a few slides that you had that weren't in the packet that we had, and one of them was about, or that I had at any rate, was, where is it? It's the diagnostic, oh, I can't find it. The diagnostic allied, do you know which one I'm talking about?
Oh, the Digital Therapeutics Alliance.
There we
Yes.
go, there we go, there we
Mhm.
go. I've lost it here.
Yes, I added that in because I realized in my last earlier talks this week that no one knew what digital therapeutics are. And if you go to dtxalliance.org, D as in David, TX like Texas, txalliance.org, they will tell you all about them. They will be happy to tell you what they do. They'll be happy. You'll see list of companies that are already there, mainly working in sleeping disorders and diabetes. But that's
Thank
the name they're
you.
going to call it at the CMS. So Digital Therapeutics Alliance went to CMS last year to ask for codes. They did not get them, and this is I'm happy to talk for hours and hours on this because I've been through all these meetings. But CMS did not give them those codes because basically what they did instead is say use the RTM codes. And so they expanded our RTM codes to only include the necessary requirement of only 2 days of data. Why do you think that is? Because that's about all doctors will do. And even if they have a PA underneath them or a nurse working in their office, 2 days of data to grab to get paid is a piece of cake. The original RTM codes only, we had to get 15 plus days plus a survey, and we had to go online with them at least once a month. So they made it easy. So digital therapeutics basically was said, which is where AI is showing up, under a uniformed name. They said, listen, go use the RTM codes. And that's what's scary for me because it's true. They will use them. Now they have access to them. And that's what we saw. These codes came out January 1st. There's no way to track. I've tried. There's no way to track how hospital systems will use these RTM codes. We don't even use them ourselves. I do, but no, not that many occupational therapists do. However, this is the ground of which we begin to give up our space. Back in July of last year, I invited AOTA, APTA, ASHA, and all the agencies to join me on a conversation with ATA around the same thing. I was very strong with my language back to ATA. You are threatening my position. You are threatening allied health to make it disappear. And they said to me, we don't know what to do, basically, right? It's going to happen because there's too much innovation money behind AI. I have a meeting next week with the executive director of ATA. This is a conversation we're going to be having in private because I'm going to encourage ATA to advocate to keep us in the loop, at least at the table. My next step after you is to go to AOTA. So I'm on the hunt now because I was waiting for the big bad bill to pass. When that bill passed, all of these things were in it. I had no idea. That's why I didn't come forward until now. I really didn't know how it was going to look. I got wind of it last May when I was handed a 65-page brief from a private equity company on the future of healthcare in the United States. When I read that, I saw that we were on the cutting block. And so I didn't know exactly how that would look. So I kept myself inside all these meetings. And at the chair position of the tele-rehab at ATA, I have the privilege to hearing some of this. I'm here today because if we aren't more concerned, and I will again share this with AOTA, in 18 months, we will be losing some of the things that we may want to keep. Now, maybe that's okay. Not everybody has to do everything that we possibly can do under OT. We're a beautiful umbrella profession. But I do think organizations like our board and the Consumer Affairs needs to be paying attention to how much we're going to give up to AI and to these large innovative companies like Meta and Google and Amazon and all the rest of them who have a lot of money that they're giving to the federal governments to have the hands-off, on AI. That's why I'm alarmed because it's no longer, you know what, too, it's surprising to me. We're no longer on that 2-year loop to get codes in and to pass them. They just pass things without us. They just They just do. We no longer are, we don't have that time frame. So we have to be, when I have a chance to jump on something like this, I'm jumping on it right now, because at the end of it, I can't save the world. I'm making you aware. At the end of it, we're gonna be giving up something. I think what we cannot give up is what you said about education. What do our students need? They need to understand and be taught the value of what we bring to the table. That's not AI. Connection, empathy, right? Decision making, critical decision making, how to communicate, how to develop trust and rapport, how to understand context, how to be empathetic to cultural sensitivities. AI is not equipped to do that. That's what we're equipped to do. So I see when students contact me, they don't have those skills. I don't see enough active listening going on, right? And so we're in a transformation around our education to our students, because when I'm sharing with you, I think you, on the slide I didn't make point of it. The first profession that's going to go are our assistants. They're going to get rid of our assistants. The hospitals are going to hire them. People are get rid of their OTAs and their PTAs. That's going to go first. And then after that, we're all on the table. That's why they didn't, they're not funding, right? Think about it. They just limited our student funding, right? For OT and PT and allied health. Why do you think they're doing that? We can't get tuition. You can't get help on federal money to get our students through college, because we're the low hanging fruit.
That was a very helpful explanation, and one clarifying question. When when they're using the remote monitoring codes, RTM codes, what I think I heard was that there is no distinction between human provided service and AI provided service in the utilization through that code. Is that correct?
That's correct.
Okay. And then one other question, you mentioned that Illinois is being active. They're jumping out in the looking at this. Where would we find information from Illinois of what they're talking about?
Well, Governor Pritzker made it pretty vocal, because this was all started because two people took their lives based on ChatGPT. One here in California, the parents have sued. They settled out of court. This prompted Gavin Newsom to come up with 3 more bills. Illinois also lost a young person to an AI bot. And so he wrote language. So I think it'd be very easy to find. Just Google, this is AI, right? But one part I do love about it, just Google artificial intelligence and state of Illinois.
Okay. But not something directly that we have knowledge that their licensing or occupational therapy board is actively presenting at this time.
You know what? Not that I'm aware of, but I would share with you, there's 34 states with pending legislation, and that's why I'm coming to the board. I think an ad hoc committee would be very powerful, because I would volunteer. I would love to spend the time to see if there's anything else, because I don't know. I'm here and I haven't heard from other OTs across the country yet. And that's why I said my next stop is AOTA. Because I went to AOTA when I was working on telehealth, and I don't know what the resources are, but we do need to take a look at what these other states are up against and whether or not it affects their Consumer Affairs Board or the Department of or the Board of OT. I can tell you this right now. I did one step further. I contacted our professional liability insurance companies, and they will support us if we use AI. So interesting enough, right? We're at a really a point of, before telehealth, when I was first here in telehealth, I was beating down doors and walls and barriers to even talk about it. Now we have the opposite. It's like an open door. Our professional liability insurances will cover it if it falls within our scope of practice, right? And so that's the tricky part. So how about if I give out a software? I don't know if AI is in it or not, because I didn't ask the vendor, and they aren't required to market AI. And I give out the software and my patient gets hurt, right? And so, and there was AI progressing the therapy. Who's liable? I posed that to the professional liability insurance company, and they said, we don't know. It'd have to be a case by case format. And I work as a legal expert. The other part of what I saw working already as a legal expert is less than a year ago, I represented a law group that was representing the hospital where an OT was being sued for an unfortunate situation that happened during an OT session. This is not about the OT. This is about the AI inside the medical record. The medical record was self-populating, right? And so as she was writing in information, it self-populated some wrong information, but she never picked up on it. But when I read the medical record, I knew it was an error by AI. So I said to the lawyer, if this comes up from the other side, I'm just going to address it as it's AI. If something else more than comes up than that, then I will address it in a different way. But right now it's an AI error. So even we see it in simple documentation, right? Because we're not making our OTs, or we just need to talk about this more. If I wasn't there to protect the OT and the other side was doing their diligent work, it looked like something was going on during that session that wasn't going on, right? So we have a lot to do here in this field of AI. And I'm sorry, I'm talking way outside your scope of your question. I apologize.
It's okay. Thank you, Tammy. Do you have any other questions?
No,
And
thank
we
you.
will address it, and we will have ad hoc committee, and we'll reach out. Actually, it's on the agenda today, so we'll establish it if you can be around a little bit later.
All right. Thank you so much for having me. I'm sorry if I overspoke. You can tell I'm very
Do you have
passionate
any other
about this. Thank you
questions?
for your listening ears.
Thank you so much for your amazing presentation. We really appreciate it.
You
Thank
got
you.
it. Thank you.
Okay. Thank you. Have a wonderful rest of your day. Okay, I think we should take a little break. 10, so let's return at 11:05. So it gives us about 15 minutes. Enjoy your break. Hello, everybody. Ready? Okay. Secretary. Oh, Christine. Phone is not on mute. Just beeping. Can we please reestablish the quorum?
Aaron Schwer,
Here.
Vicky Santos,
Here.
Matthew Greco. Here. Louis Arabit,
Here.
Ida Boone Hurl, here. Christine Whitlisbach.
Here.
Yada Marcos.
Here. And we have a quorum. First thing, we have to go to public comment on the previous agenda item, which was 21 presentation on the AI. And do we have any public comments regarding that? No? All right, moderator, can we open it up on WebEx, please, for any public comments?
This is
Thank
the
you.
moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click that raise hand icon. Or if you're an audio only participant, you can raise your hand by pressing *3 on your device. And I do have a couple requests for public comment. First, I have Wendy Nielsen. And Wendy, I'll request to unmute your microphone. Please click the unmute me button when the prompt appears on your device.
Hello, thank you. This is Wendy Nielsen, Sacramento City College. I wanted to just profusely thank Tammy for her presentation. I had also listened to her presentation to OTAC earlier this week. Both of them so informative. I'm not sure if this is the appropriate time, but I'd like to volunteer to be on the ad hoc committee for AI. As I hear the AI safety concerns, not just amongst us, but safety officers at AI companies are sounding alarms that the world is in peril with ethical, moral, and environmental and human autonomy at risk. So I appreciate the board considering these concerns.
Thank you so much, Wendy.
All right, this is the moderator. Next, I have Jana King. And Jana, I'll request to unmute your microphone. Please click the unmute me button when the prompt appears on your device.
Thank you, Sarah. Hi, my name is Jana King. I am with SEIU United Healthcare Workers West. We're a healthcare union of more than 120,000 allied healthcare workers throughout the state of California. And I just want to say thank you, Tammy, for the presentation. I just appreciated it so much. Grateful for all the content that you presented. Took lots of notes, and would love if you're open to sharing contact information. I know we at SEIU UHW would like to be able to be in touch with you on this really important topic for us as well. Thank you.
All right, this is the moderator. Appears there are no further requests for public comment at this time.
Thank you so much, and thank you for your comments. Okay, we're moving on to agenda number 15 from yesterday. And we had to transfer to today. Discussion and possible action to consider initiation of a rulemaking to amend sections 4180 and 4181 supervision parameters of Title 16 of the CCR. So I would like to start. The reason why this is before us, this was 2 years in the making with coming up with this language. And AOTA and OTAC and the board ended up being on the same page, and everybody's happy. But however, we need to just clarify a couple of items, just so our executive officer, when he proceeds with these regulations, he can back it up. And so number one thing would be that on page 3 out of 3, where it says aids providing client-related tasks, and then number 2 is level 1 fieldwork students. So, and then number 3, that it says at any one time. Number 4 also says at any one time. However, the first, 1 and 2, they don't have it. So I know, Ada, you were on that committee as well. And if you could, based on, obviously we understand at any given time, so we don't have somebody who is, today they're overseeing 3-4, and then tomorrow is going to be another 3-4. So, but the distinction of why is it under, it's, not under AIDS or level 1 field work, but it is at level 2, occupational therapy assistants, limited permit holders, it's stated over there. And then moving on later on in the different section with the occupational therapy limited permit holders, again, it says at any one time. So based on what is before us, how could you explain the fact that the other ones don't have it? That it doesn't apply to everybody, that is at any one time.
I could perhaps clarify a bit more of what maybe I'm hoping to get clarification on as well. And this could be something that knowledge that I don't have because I'm not an occupational therapy practitioner. So maybe this is something that is obvious to somebody who practices in the profession. But I guess my main concern with explaining this to the Office of Administrative Law and coming up with the justification and rationale for why these specific changes are being made. If we take a look at G, and we were looking at D earlier, but there's some parity between D and G. So let's say, for example, G1, level 1 fieldwork students directly engaged in client-related tasks or patient-client care. No limitation on at any one time. And then level 2 fieldwork students at any one time. So if I were a practitioner, am I to take that to mean that on Tuesday, I could be supervising 3 level 2 fieldwork students, and maybe on paper, I am their fieldwork supervisor, but then on Wednesday, they're not actively at that specific time engaged in their fieldwork. I could then go and supervise 3 other people on this list. Was that the intention of?
If right, so if that next day you went on to go to a different group of 3, then there's your at any one time, even though these are not doing any kind of client related activity, they could still be in the facility. They could be doing other duties as assigned, might be a way of looking at that. You wouldn't say that really, I mean, in terms of clinical supervision, you're supervising 3. You're not supervising 6 at that moment.
Right.
They are under your guidance, but it's not any kind of patient care activity with the 3 doing a research project or a inventory project while the other 3 are doing client-related tasks.
That clarifies a little bit. That helps. I'm then curious. It kind of begs the question: why then, on some of these categories of supervisees, is that not included?
I can probably clarify that. I
Thank you.
attended as part of these things, but the different levels of supervision required for the different activities, right? So level 1 fieldwork students are not supposed to be directly responsible or involved in direct patient care.
Mhm.
They're more observation and learning status, so that the ratio of supervision is not as
Strict.
strict, right, as intense, because the idea is that they are learning about the process and not actually involved or expected to be involved in the care of clients. So they will never be at risk of hurting anybody, whereas level 2 students are.
And that's what I thought first, but then it says level 1 fieldwork students directly engaged in client-related tasks or.
So they would be, and I think that that's still important to have in there because of they're still there. They still may be assisting. They still, depending upon the situation, we may allow that student to experience something, but with a lot more.
I guess what I'm. Oh, sorry. Go ahead.
In the example of the co-treatment, for example, I am running the session. It is my patient. I'm running the session. I'm saying level 1 student here, do this task for a moment or two, in a brief component of it. They're not providing the patient care. I'm providing the patient care. They're operating as an adjunct in the moment.
Okay. I guess maybe if I look at it from the opposite angle from where I was coming at before, let's say that on paper I am responsible for the supervision of 3 level 1 fieldwork students directly engaged in client tasks or patient client care. Now this item doesn't have the at any one time. So at what point in time am I considered no longer responsible for their supervision and able to take on other people on this list? Because there's no at any one time there. So does that extend indefinitely? At what point would I be able to start supervising other people on
Yeah,
that
that's where it
list?
gets tricky because I think the academic requirement is not. The academic requirement helps to dictate how we set up Fieldwork 1 experiences, and it could be in a larger group.
Mhm.
So if they're observation or if they're, different settings, you could have up to, it could be one therapist with 9 students there, but they're not, and they're there and involved, but they're not.
They're like technically on paper sort of supervising, but not directly supervising.
They're not direct, the students are not going, in those instances, the students are not going to be responsible for any of the patient care at all.
Right.
They may be responsible for setting up an activity, doing cooking, things like that, but they might not, but they wouldn't necessarily be responsible for they're more of an observation status, and that's the academic requirement. So I think the at any one time is to allow for that and not to put restrictions on the ability to schedule level 1 experiences for students.
Right. Okay, I see why that was left off then there now. So I guess as long as nobody seems to feel like that interferes with their ability to supervise the other people on that list, then that clarifies it for me. I just wanted to make sure that that was the intention.
There's also a number of hours that students in Fieldwork 1 might have. Some of them may do their fieldwork in just 1 week, and it's 40 hours. That's what I understand. But some schools require more than 40 hours. But technically, it's really always 40 hours, and it depends. It could be scheduled throughout the week or in probably many weeks. a few hours here and there, as long as they meet the 40 hours.
Thank you. There was one.
May I
ahead.
stay on that just a moment? Because I'm trying to go through here because there should also be the OTA in supervision of this. And so I see it's referring in G to occupational therapists. But then there's also the OTA's ability to supervise. And I'm not finding that in these materials. Am I
It
missing?
is, it's broken up across pages, but section D, starting at the very bottom of page 2, deals with the occupational therapy assistants, and then it continues on to the top of page 3.
Yeah, I don't think I have that page. That's my problem. Maybe. Oh, here, I'm sorry.
We might be able to get another copy for you. Just one
No,
moment.
here, I just had it. Occupational therapy is total of 3 of the following. Okay, okay. I just wanted to make sure that we had the continuity. All right, thank you very much.
Of course.
So, Dee, would you like to?
I just wanted to clarify or just make sure that I understand. So for example, for D with the OTAs, it says they may supervise no more than a total of 3 of the following, and then you have those 4 options. Does that mean at a single moment, an OTA may supervise any 3 individuals that can hold any of those titles?
So it goes back I'll skip the aid for the moment, but in the level 1 fieldwork student, it still would not have that at any one time due to the diversity of how level 1 fieldwork is run. So I mean, I could have a whole large group of students.
Are you asking 3 of each? Or
Yeah,
if it's a
I guess
total of
3
as
of
a
the
combo?
I guess I just don't know what 3 means. Is it 3 individuals or 3 categories, or what is the 3 referring to? Because
3 is the number of of students.
Well, it's,
Or
what she's asking, I think, is that it says no more than 3 aides, 3 level 1s, or 3, like, so is it 3 of 4, or is it 3 of each?
The way it's written,
Mhm.
at the end of 3, at the end of that line, and
Mhm.
I think that the way it's written, I think it implies that you could supervise 3 aides and 3 level fieldwork students, and I think that
Yeah,
"and" makes that
it-
so.
And I think it may be best to include a total of 3 individuals from the following categories, maybe a little bit more
What
clear, but
may what is the intention? Is it is it that you have 3 practitioners total from any of these categories or 3 individuals from each of these? What is the, regardless of what it says, what is the want? What do you want it to say?
I think that it's no more than 3 from each.
So you could have
And.
12 individuals. That was the intention? At anyone, at
No.
any time?
I
No.
don't believe so, no.
Sorry,
3 total.
3 total.
3
It could
total,
be from
regardless of
different
category.
Okay.
Yeah.
And so I'm going to add the at any one time. So at any moment in time, an OTA, and this will go for OTs as well in the separate category, may supervise 3 practitioners. They must come from one of these categories, correct? And so what does adding at any one time to one of the subdivisions, what does that add if at any moment in time you can only have 3 total?
Because you may have a rotation of
Okay.
fieldwork students is my,
Okay, so it's that I could have, we're going to call our people A, B, and C. I could have A, who is an aide, B, who is a level 1, C, who is a level 2, or I could have 2 level 1s and 1 from somebody else. But for level 2, is it different? I can only have.
could have 2 level 2s and
Mhm.
1 aide.
Mm-hmm.
Or I could have a limited permit holder, so that means I can only take 1 level 2 student at the time until that student goes. Then I might be able to take more level 1s.
So adding at any one time to subsection 3, for example, the level 2, that means that I'm only allowed one level 2 at a time, or I could have multiple? I'm just sorry. And I apologize for asking this. Just I wasn't here before, and I want to make sure
This is good.
that it adds value and doesn't
This is
only
good.
add confusion. So
It's good because it would depend upon the makeup of who else you have, right? So I could have, if I don't have any of those others, I could have 3 students, 3 level 2 students.
level 2. And could you also have 3 level 1?
Well, that's what I was asking with this, is
Okay.
that,
So would everybody be okay with 3 level 1s at one time?
yeah, oh, at one time.
At one time.
My question was, could I have 2 level 2s and 2 level 1s? But that would
Yeah.
exceed the 3.
Right. So I think, so are we all in agreement that 3 is the cap? Okay. So I think it makes sense under D and also under G, so that means OTAs and the OT, to include something like individuals or practitioners or something showing that it's a singular 3 of them.
May I add something on there?
Yeah,
Because
please.
when I read this, when I kind of feel like I'm remembering this, because this any one time was a long discussion.
Mhm.
And so I, what if just each of those 3 lines said at any one time?
I think I'm in agreement with you. I think it could either all 3 say it or all 3 not say it. I'm not understanding the distinction when we're saying at any one time what
That's
the
where
practical
I'm at as well.
impact is.
And I think what it was is the format became a list of categories,
Mhm.
comma, at any one time. I think that's the formatting that ended up, because putting it in and out became a confusion because it
Mhm.
was a long discussion.
And so the point of it at any one time is that you can have a level 2 person, then they leave your supervision. Somebody else can come in. It's not you're stuck with the same 3 people.
Or
at
that in 1
20
year, I
because-
can only have 1 student
Yeah.
at a time. Like I can,
Okay.
Mhm. Would it not accomplish that to just, they're all at any one time, right?
Yeah, that's
Okay.
what I think. I think we could add language that that means that under the D and the
Yeah.
G rather than under the
On each
subdivisions.
individual line.
Yeah.
So something, I mean, this could be changed a little bit, but for example, occupational therapists may supervise no more than a total of 3 individuals from the following categories at any one time.
That's
And then
what
your
I think.
categories.
Yes.
Okay.
Does everybody agree with that?
yes.
Okay. Good. So the edits that Austin said, they will be identical under D and G, having to do with OTAs and OTs. And I just want to note that there's also a subsection here that I think accomplishes the concern about being able to supervise level 1 fieldwork students who are not in client-specific hands-on, but rather in an observational role. It acknowledges that OTAs may supervise no more than 20 level 1 fieldwork students in a faculty-led fieldwork at any one time, meaning
And is
they
there, and the same is for an OT.
yes, perfect. And there is also a without limitation. Without limitation, OTAs may supervise, subpart 2 says, level 1 fieldwork students exclusively in an observational role. So I think that was
Yeah.
to your point.
Right.
Okay. Okay. Yes.
Thank you for that. That's
Yes.
helpful.
Mhm.
When you say faculty led, I just want to make sure I understand. Does that mean that the faculty person is on site at all times?
Correct.
Okay.
Or that it's at the university with.
So this
Corona.
language actually does include a definition of faculty-led in
Mhm.
4180.
I think it needs to, because you just said something I didn't hear you, or the faculty person is at the university?
Or
and
the field work is happening at the university with clients that come to there.
I gotcha,
Right.
okay.
So faculty led, it just means that the faculty is the OT that is supervising. So it's.
I think that's important that we add a definition, because otherwise you're going to have people be like, okay, I'm your supervisor, you 20 go on out to the OT. I'm faculty led,
Yeah.
I'll stay in my office.
Oh, yeah.
Yeah.
So
I
the
think we need-
current
yeah.
definition under 4180, subpart F is faculty-led fieldwork means, I'm going to read it with my very minor edits that I think make it sound a little more clear, but faculty-led fieldwork means fieldwork completed under direct in-site supervision of a licensed occupational therapist or occupational therapy assistant employed by an accredited California educational institution.
That does it.
That sound okay? Okay.
Mhm.
So Austin, I have that minor 2-word edit.
Under direct.
Yeah, and striking the word A under means A field.
The other thing that became a complication in this discussion was the use of virtual field work, where that really kind of just got like, oh, that's too much. I don't think we're going to address it. I don't know. It's kind of not really captured, but
Okay.
if just to account for it in this discussion,
Mhm.
for example, we use a virtual online platform with no patient risk, no consumer risk at all, that for level 1 field work, and the ratio is 1 to 30. And so, but that's not really captured because it really is like a didactic class, and a self-directed learning once you learn this electronic platform. So I don't know, especially in this digital world, it just feels, because I balked and fought back on it for a while on the 20 because it was faculty led. That means I can't teach my 30 students. I can only teach 20 of them so it became a confusion. So I don't know if we want to add simply a
It-
statement.
And I think we
saying-
left it out during that discussion because of the fact that there wasn't direct patient care.
Right.
If there's no
Was-
client related services as part of that, then I think that might fall under the subsections in here for OTs and OTAs saying without limitation, level 1 fieldwork students exclusively in an observational role or providing non-client related
Perfect.
tasks.
Yeah.
Thank you.
Yeah, agreed.
Okay, just while we're at it, thank you.
And
Okay.
then would you still like to clarify whether or not you're okay with in section 4, subdivision E, occupational therapy assistant may supervise no more than 20 level 1 fieldwork students, as well as the occupational therapist may supervise no more than 20 level 1 fieldwork students in J? Yeah, I. Is
Um,
is everybody still?
Yeah, I think what President's referring to is that under OTs, it's just that the supervision allowed is identical. It's both may supervise no more than 20 level 1 field work. That's correct. Great. The other question I just had, should I just the entry
just-
level?
Did you mean E and I?
Yeah, E and I.
Sure did.
Just to clarify.
I don't know what I said, but yes, yes, E. No, actually, E and H. I did mean E and H. Sorry, as written.
I here.
I'm seeing it as H. Let me see what you.
H is in addition to the supervision limits.
Oh, I am seeing H.
I think
I'm looking at what you
I
said.
may have, there may have
Oh.
been an update that I might not have given you. I'm so
Okay.
sorry.
Okay, that's okay. What I'm referring to are nearly identical sentences, and I just want to make sure that that applies to OTs
The no
and
more
OTAs.
than 20
Yes.
level 1. Yes.
Okay.
I think in the materials that the members in the public have, that would be E and I.
Okay. Okay.
Not
Sorry
trying to
about
nitpick,
that.
just for the record.
Just keep, yeah. And then the one other question I had in 4180, we define doctoral capstone students, and they are called entry level doctoral capstone students. I wanted to understand why we are referring to entry level. Do they need the word entry level?
So entry-level doctoral capstone students are not licensed therapists, but our post-professional doctoral capstone students are.
Okay.
So there is a different type of doctoral capstone
Yes,
student.
we
to
have a
distinguish
doctoral
from.
capstone entry-level student that would not be a licensed practitioner,
Got it.
but the post-professional will be, so they would be covered under the
Okay.
So that qualifier needs to remain.
correct.
Perfect. Okay.
Okay. Thank you.
Thank you.
Do you have anything? else?
That cleared up everything for me perfectly. That was all the things that I needed clarified to help push this through the regulatory process. So thank you.
So do we need to vote on this?
We will need to vote if
And-
we want to take this language as presented or with the edits in the meeting.
Yeah, for motion purposes, please.
Yeah, I
Oh.
guess we'll go to public comments first.
Okay. Thank you.
Yeah.
That was fantastic. Thank you. This is Sammy Rafidi from Occupational Therapy Association of California. Just a few things now. I know that we were about to go to the motion, but I just have 3 more things that I want to clarify and or ask. Under F, for the OTA, where it says, without limitation, occupational therapy assistants may supervise. And then it lists entry-level doctoral capstone students completing an experience in research, skills, administration, leadership, et cetera. Everyone's there? Yeah. Could we add, like at the end of the sentence, it says, as required by an accredited educational program. Could we add something like, as appropriate to the setting and required by an accredited educational program? Because I think it would be relevant to make sure it's appropriate for each setting. What did you say?
I said, I like where you're going with that.
Yeah.
Because I can foresee a situation where the student has a project that idea or something that's not relevant for the setting and could put the consumers at risk.
Yeah.
Okay. My only concern would be that I will have to define what would be appropriate to the setting when we push that through. So that might require a definition of some kind, or I don't know. And that again could be my lack of familiarity, not being a practitioner, but maybe that's more self-evident to.
It's going to be difficult though for the office to monitor this when it's so nebulous. I understand what you're saying.
Yeah.
But it's difficult to enforce when it's.
Could you give me an example of a hypothetical example of somebody doing this in a way that's not appropriate for the setting?
Like if a student is in a hand therapy clinic and they want to do a project about school-based occupational therapy for children.
Right.
When would that ever happen?
It wouldn't, but this is an extreme, of course.
I'm just trying to.
I hope
What
it
is the
wouldn't.
need for this?
And then would this be more of oversight on the academic side as opposed to a license issue?
Okay, let me try to think of another.
I don't know.
Yeah, let me think of something else.
I'm not trying to minimize. I'm just trying to think, are we over regulating or putting too much concern on this one that might not be, and making it more difficult to enforce?
Yeah.
I have a question. This is legal. Would it be acceptable if, upon enforcement, we found that it was not appropriate for the setting, that would go under unprofessional conduct? So they would be charged with this if it was, the educational, but if we had something that was in an inappropriate setting, it would go under unprofessional conduct. So that would be our charge and that would be current.
I think it goes back to Christine's comment, like, would someone in a hand therapy clinic ever do something in school-based? They probably just wouldn't. Doesn't make sense.
And that might be more of that academic, right? We all have the doctoral coordinators that are supposed to
Yeah,
be
that they're
supervising
overseeing
that.
projects. Okay.
Yeah, thinking it from the viewpoint of the coordinators from the academic side.
They
should prevent this from happening.
Okay.
Yeah.
So as required by an accredited educational program should cover that. Okay.
It was a good idea, but in reality, it does, I think, come back to the academic side's responsibility for assigning the right student in the right setting.
Okay. Yeah, appropriate also is just so vague. All right, I'm okay. Scratch that. Okay, other things. Under the thank you for that, and thanks for walking me through it. That was helpful. Under the occupational therapist being able to supervise, so this is G, the occupational therapist may supervise no more than a total of 3 of the following. I don't see aids listed. Rehabilitation aids are not there. So I think that should be added. And I believe that was a conversation we had in November of 2024, but somehow didn't make it on here.
That's a good catch.
Perfect. No, that's where I'm glad that you brought it up because that was a long discussion And my fear is that maybe something got missed. So thank you.
Yeah, sure, sure. And then just had one more thing that's on the previous page, on page 2. Yeah, it's on page 2, and no, it's not 2. Hold on. Okay. It is, yeah, it's on page 2, but it's on page 2 of the first page of this section. It's called Excerpt from November 14th, 2024 Board Meeting Minutes. And it starts with Agenda Item 12, Consideration and Possible Action to Initiate a Rulemaking Package to Amend California Code Regulations, that page. So on page 2 of that document, it says at the very, very bottom, Kristen Neville asked for further clarification about whether the board intended to support the ACOTE standards when using the term direct supervision and whether it should be defined in the language. The board determined that would best be addressed as a separate motion. I don't know if that motion happened,
I'm not sure either.
but I would like to remind the board that that was an agreed upon, that was a conversation that everybody agreed on would be a good idea, because the way that direct supervision is defined by ACOTE should be in the Practice Act as well. And I want to read that to you because it makes a difference. So in a letter that was sent to CBOT by OTAC in November of 2024, we asked that the board define direct supervision with respect to supervising level 2 fieldwork and adopt the same language that is used by the Accreditation Council for Occupational Therapy Education to read, quote, level 2 fieldwork supervision is direct and then decreases to less direct supervision as appropriate for the setting, the severity of the client's condition, and the ability of the student to support progression towards entry-level competence so as to not further limit the work that practitioners do in a clinical setting. So I think it's important that the definition of direct supervision parallel the definition that ACOTE has provided.
And just so the main difference in the definition provided in ACOTE is that for a level 2, the level of supervision considered direct decreases over time.
That's right.
It's only affecting level 2. Okay.
That's right.
I'm just trying to see if there's anywhere in the text as proposed that states level 2 fieldwork supervision must be direct, in the sense that it would preclude it from being interpreted that way. Um, if every time it mentions may supervise level 2 and it doesn't stipulate that it has to be direct, then it could be, there's nothing precluding it from being taken that way. Right. Thank you. Okay. Well, if we wanted to add that, we would need to add it before D, but that is up to the board.
Just a quick question. Are we proposing adding a definition of direct supervision or clarifying?
I think what's being proposed, and correct me if I'm wrong, is adding a definition to 4180 to define direct supervision. And having that definition be the definition used in the ACODE standards.
Yeah. Is supervision defined anywhere, direct supervision defined in the Practice Act?
what qualifies as supervision is defined in the regulations. I don't believe it's defined in the Practice Act, but let me double check on that. I know in the regulations we have a section that defines what are the minimum requirements of supervision, but let me check the Practice Act.
But this is only is directed to direct supervision of a level 2 fieldwork student. This is the definition of that direct supervision, not anyone else.
Right, because level ones don't do patient care.
Right, it wouldn't be direct supervision of an aide or it's only for level 2 fieldwork supervision. It doesn't have anything to do with the direct supervision of a COTA from an OTR. It's only level 2 fieldwork student.
So in that instance, could we just say under direct supervision of a licensee as defined by the Accreditation Council of OT Education?
Helen can stop me if I'm wrong here, but I've recall her making clarifications in the past that makes our regulation subject to any changes that ACOT may make. So not saying that they're going to just totally change their definition of direct supervision, but it might be better just to verbatim copy it.
And just add it to the line in D?
So it could be anywhere in 4180 technically, but I think because 4180D references the term direct supervision, it would be helpful to define it prior to D.
Got it.
So A, B, or C, take your pick.
If we do define it in 4180 and we are concerned only about direct supervision as it has to do with level 2, we need to not, I'm reluctant to do just a direct supervision definition because it is going to be the only definition in our regs to date that is defining direct supervision. So if it's only about level 2, we could even put it in subdivision
Like
D.
D1.
It could be D1. It could be level 2 field work or participation delivering occupational therapy services under. I need to look again at the ACOT definition that you read, but we can use that language in that little subsection of just add a comma and make it make sense, but in a way that is not making a new and separate definition. Could even say, and don't quote me on this forever, but under direct supervision of a licensee, and which supervision decreases. Where is it?
Decreases to less direct supervision.
As appropriate for the setting. Right.
It's kind of wordy.
I'm going to think about this a bit because it's wordy and what is the appropriate setting and what is less and at what moment do you decide that? I think it's adding more than just a 2-minute conversation decision on the language right now to this subsection. But thank you for bringing this up, and it is very important to include. And it's something, honestly, that for a later date, we should define direct supervision. And there's also the language direct in-site supervision is used for faculty-led fieldwork, which also raises a little bit of a feeling and a flag in my mind. So these things do need to be defined. And I think that at some point it makes sense to have a section in our definitions in the regs that define the various levels of supervision. So at this moment, I'm not going to recommend a edit here, but I think we need to think about it a little bit.
Right.
Mm-hmm.
I just wanted to make sure that that doesn't get missed since there was a discussion about it and it was meant to be addressed as a separate motion when Kristen Neville was here in November
Okay.
of 25.
And
24.
it is on the record for this meeting as well now too.
Okay.
So
Great.
I don't know if we need a another motion for that since it'll be handled in the future. Um,
There could be a motion. Well, Helen, correct me if I'm wrong, if it wasn't. I mean, the definition, this motion was not on the agenda. But can there be a motion that the board wants to take the ACOT definition, the same motion that was on the agenda previously that was never voted on?
The board would have to see the language to know what it's voting on.
Mhm.
And since we need to figure out exactly what that language would be, I'm not sure that we have enough to even make a motion.
Okay, I was meaning just the ACOT language, but I know that we want the language to be voted on, but I do think the supervision portion is important. And so my recommendation is that we tweak that and we finalize it. And then I think the rest is all very settled and everybody's on the same page. And I think we worked through some good edits, but I think that we should
bring it back.
finalize the supervision piece and bring it back to you at the next meeting.
And so then would the motion be to, you know, to do a scoping review of definitions within, or just leave it?
I think we can leave it as is and we'll do the work on the back end and we will present it to you and it will be presented ahead of time in meeting materials and you could have adequate time to look at it. So you're ready to vote and discuss at the next meeting.
Thank you.
Okay.
Thank you.
Thank you.
Thank you so
Appreciate
much
it.
for the comments and clarifications and everything. So, do we have any other public comment? Can we please open it up on the WebEx for public comment?
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click that raise hand icon. Or if you're an audio only participant, you can raise your hand by pressing *3 on your device. And I do have a request from Wendy Nielsen. Wendy, I'll request to unmute your microphone. Please click the unmute me button when the prompt appears on your device.
Thank you, Academic Fieldwork Coordinator, Sacramento City College. So vested interest here in this. My apologies, I don't have the paper right in front of me. Just clarifying that the wording is clear, that the cumulative effect of an OTR's license with the no more than 3 from any category at any one time includes students that may also be being supervised by the OTAs that are under that OT's license.
Is the question regarding?
Maybe it's a comment.
Are you referring to like if a OT is supervising an OTA who is supervising students, like that sort of
Correct.
chain
Correct.
effect?
Correct.
I remember that discussion occurring back
Yes.
in 2024, and I think I'm not qualified to answer that, but I remember there being consensus about the language addressing that appropriately.
Okay, and so where we are at now is sufficient, correct?
That's my understanding from
Okay.
the 2024
Perfect.
meeting.
Perfect. I just wanted to make sure we had covered it. Thank you so much.
Thank you.
All right, this is the moderator. It appears there are no further requests for public comment at this time.
Thank you so much. Okay, then we're moving on to agenda item 22, discussion on Assembly Bill AB 489, BANTA, healthcare professions, deceptive terms of letters, artificial intelligence. Discussion may include how to adopt regulations to implement this bill and the benefits of establishing an ad hoc committee on artificial intelligence in healthcare professions. Do you have an overview on the bill that we heard about a little bit earlier from the presentation?
I do. The board may have heard about this bill outside of the context of this meeting or at previous meetings, and in the context of Tammy Richmond's presentation earlier. But essentially, this is a bill that passed that prohibits anybody who employs the use of generative AI for that AI to use limited terms or letters. So, for example, OTL, OTA, that they are implying that they have a license to provide healthcare services in the state of California. Um, this is something that may or may not need regulation adopted, and this could be something that is discussed by the committee in the future. So we don't have to necessarily come up with regulatory language today, but given that we had the presentation from Tammy, I felt that it would be important to provide this text to the board and maybe raise a couple of questions in terms of what does this imply for the board's responsibility for monitoring this type of behavior or these actions. So one thing that stood out to me is who is responsible for the violation? What if whoever has deployed this artificial intelligence model that is providing services is not a licensed occupational therapist or occupational therapy assistant? The board doesn't have the jurisdiction to simply issue them a citation like we would for an occupational therapist or occupational therapy assistant. So that might be something that the committee wants to consider, and maybe legal might have advice about what would be the appropriate action to handle a violation by somebody who's not a licensee of the board. I think that's the most ambiguous part of this law for me.
Thank you. Helen, do you have any? Board members, what do you think about this bill?
I think this is an important conversation for the ad hoc committee.
Okay.
And for me, the salient piece here at the moment is, ensuring that whatever advice, care, reports, or assessments being provided, in distinguishing, transparency of the source is like, if this is generated by AI versus written by your occupational therapist.
Okay.
Or written by your occupational therapist with the support of AI. Because, then we're getting really murky. Yeah.
I was just going to say that we have the RUG meeting next week, which is where EOs and regulatory analysts, various staff members from the different boards get together and meet with DCA. And this is applicable to all healing arts boards. And I think we don't want to have to think about, you don't need to think about it in a vacuum. And you have others that are considering this too from different angles. So I think it's worth, I'm happy to bring it up and just see what are other people thinking, and or we have various subcommittees to get people together. So I'll keep you apprised on that.
Thank you so much, DP.
Is there a healing arts board or healing arts like task force specifically addressing AI in consumer protection?
I do not know about one. Helen, do you? Yeah. I frankly don't think there is one, but yet we'll see. We'll see
Not
what's
yet.
next. Yeah.
And this isn't on the agenda specifically today, but just as a aside, Senate Bill 903 deals with that transparency. That might be.
Thank you, everybody. I guess we're gonna. Do we need to go to public comment before we move on? That's true. Do we have any public comment regarding agenda number 22? Not in person. Can we please open it up on WebEx?
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raise hand icon, or if you're an audio only participant, you can raise your hand by pressing *3 on your device. All right, and it appears there are no requests for public comment at this time.
Thank you so much. Going to move on to agenda number 23, discussion and possible action regarding the board standing and ad hoc committees and committee membership, including the possible establishment of an ad hoc committee on artificial intelligence in healthcare professions and the appointment of committee members to any of the board's committees by the board president. So I heard some volunteers would like to chair the ad hoc committee for the artificial intelligence. And I'm not, can we do co-chairing or do we have to have one main chair and then?
I don't know that I have that answer right off the bat, but I've not known of a co-chair.
Me neither, that's why I'm double checking.
There's nothing in the board's administrative manual that prohibits that, but there's nothing that establishes that as an option.
Okay.
I mean, there
guess-
could be a, what would be the equivalent of a vice chair?
Okay, we can do that. So Erin, you're gonna be the chair and Louis, you wanna be the co-chair? Oh, no, wait, she just said she's gonna chair it.
Oh,
It's not. You tell me.
I am happy to chair with Louis at my side.
Perfect. I love that. And then I know Ada, you were interested, but that would be too many board members on the committee. So you can, I guess, she can join as a public, right, to make comments, or is it too complicated?
Well, a quorum is 4, correct?
Not on the ad hoc committee.
Oh, the ad hoc, okay. If it creates a quorum, then she can observe but cannot speak or participate in any way. But I'm not sure if there are special rules for an ad hoc committee. But those are the general rules. If a quorum is not created, it doesn't create a secret board meeting, and therefore the party can participate. As
But the
minute
board
a
meeting
quorum
would
is created, it has to be silent.
But the board meeting would be 4, so if it's
Yeah.
3, that should be fine. You would like to be on it, right? If it's.
I'd like to
possible?
participate if I could, but not to generate a problem.
If there's special rules for an ad hoc committee, I'd need to look at it. So I'm not
Okay.
available for that
So
answer yet.
we'll put that on hold for a second, but
So I'm just going to lay low. So, but have the committee is more important than my participation in that. Please move forward with the committee and then we'll figure me out later.
okay,
Yeah,
we'll let you know.
thank you.
And then I heard that Wendy Wilson would like to be on that committee as well as a public participant.
Wendy Nielsen, Neilson.
Okay. Sorry, Wendy Nielsen. I don't know what. Is she
Still
still,
on.
moderator, is she still available, or she's still part of the meeting on WebEx?
Yes, let me go ahead and request to unmute her.
Thank you. And also Tammy, right?
Yes, I'm here.
Tammy. So would you like to be on this committee, ad hoc committee?
Yes, please.
Okay, thank you so much for volunteering.
Mhm.
And then, is Tammy still with us?
I think Tammy communicated to me that her availability today only extended until 11, so I don't think she's on, but we can reach out to her.
Okay, so we'll reach out to her. And then if there is anybody else who would like to be on it, please let Austin know. And we can, go from there. But for now, at least we have it almost up and running.
May I ask a procedural question in terms of what distinguishes our decision between making it an ad hoc committee versus a standing committee?
I actually have that answer right in front of me.
Wonderful.
So an ad hoc committee is one that is formed for a specific purpose, usually a specific short-term issue or project. A standing committee is usually longer term and/or set forth in the statute as a committee that is expected for the board to have. For example, we do have one board that has an enforcement committee that's actually in the statute. And we have, I believe with this board, we have like a practice committee that's long-term, and that would not be like an ad hoc committee.
Thank you for that. It's very clarifying. And so my question then becomes, would this, because of the pervasive nature of AI, it be better to make it a standing committee?
I think we're only going to,
Yeah.
I think we're only going to be promulgating rules and regulations in the short term. I mean, and not to say that we wouldn't do, that wouldn't evolve over time, but I think the substantive part of the work is probably, yeah, I think it's more appropriate as a short term.
And also, if we had it as an ad hoc committee, once we kind of had our feet set, there would be nothing to stop it from moving it into the practice committee as part of the topics as relevant.
Thank you for helping me understand all of that. I appreciate everyone's input. Thank you.
All righty, and then we have a few vacant seats on other committees, such as Education and Outreach Committee, which is a standing committee. Would anybody interested to be, from the board, to be on that committee?
You became the de facto chair by board members getting off on some fees. So if
Kind
you're
of
not-
figured.
If you're not interested in being the chair
Oh.
anymore, make that apparent.
Right, I don't have to be the chair for that, so if anybody would like to step up.
I wouldn't mind stepping up, but I can't do it at this point in time over the next few months.
I don't think we're planning on meeting in the next few months.
Okay.
So,
From July on, I could take that committee.
The Education and Outreach Committee and the Legislative and Regulatory Affairs Committee, I'll point out, don't have any immediate need to meet. The reason we're seeking members for them today is because our administrative manual requires a minimum of 4 members for these standing committees. So volunteering is not a immediate time commitment for any, except for the practice committee, but for the other 3 committees, there's no plans to meet in the immediate future.
So right now I could take the vacant seat until July. Is that what I'm hearing? And we've got what we need there. And there's plenty on the practice. Thank you.
I'm more interested in the Legislative and Regulatory Affairs Committee.
okay, you're on it.
I'll join Christine on that one.
Well, actually,
We have 2 seats.
oh, we have 2 seats? Okay,
Yeah.
you have a chair?
You are.
Yeah, well, yeah, I would be interested in passing that along to someone else.
Would you like to be the chair, Louis, for that committee?
No, no.
Oh, sorry. Oh, Matt.
Don't you think he'd be,
Oh, no, I definitely wanted him to be on it. I just, I would have to ask him if he would want to be the chair on it. I think you should do it.
Yeah, I'd be happy to be the chair.
Okay.
Louis or Christine.
I don't want to be the chair anymore. The reason, the practice committee is.
It's a lot.
Takes up a
yes.
lot of time.
Okay, so Matt, you're going to be the chair for the Legislative and Regulatory Affairs Committee. And then it would have to be Louis or Christine if you still want to stay on it.
If you're interested, go ahead. With regulatory and legislative committee. Well, you jumped up and said you were interested in it, so I'm okay if you do it.
Okay. No, because Matt is going to be the chair. Oh, you mean like because,
Am I,
oh, well,
how many people can be on it in addition to Matt?
well.
So it's a question of how many board members could be on it. So we can't have more than 3 board members, but at the same time, the administrative manual requires 3 or 4 committee members minimum. So there has to be at least 1 non-board member, committee member on each of these committees.
Okay, so Louis and I could both serve on this committee. Okay. So Matt will be chair and Louis
Okay,
and I will sit.
unless somebody in the audience wants to be on it.
Oh, Vicky.
Oh, Vicky too.
Yeah.
Wait, Vicky.
Me?
That's
I
again,
can
board
if you
member.
need me to. I just didn't know because I was a board member, if I could be on it.
I would step down if she's interested.
Yes, but do we still want somebody from? the
We
public to
need
be-
somebody from
Yeah,
we need someone from the public. But let's see if Vicky wants to be on to see.
it's Legislative and Regulatory Affairs Committee, which you would be very good at.
Who?
Samia.
Oh, yeah, Sammy would be great.
Well, Why do you think I'm winking in the audience? But so we then, if Samia is on, then we don't have to have 3 board members. And
Yeah.
then she can be, or
Austin
she
just
can
said
be.
we had to have 4 people.
There has to be a total of 4 people.
Yes.
That can be any combination of board members in public as long as it is no more than 3 board members and at least 1 board member.
Right.
According to the roster,
So we still, yeah. So if Samia joins, you don't have to be on it. So because then we have Matt, Louis, Samia, and Kristen.
Sure.
so it might be a good idea to just figure out the board members. And then if Samia wants to volunteer because she's here in the moment, that's very easy to get her added on. But for most of these committees, I don't think you're going to be able to fill them because we mainly just have board members here and we can't have 4 board members. So it might just be a good idea to figure out which board members will serve on each of these committees, and then we can take interest from members of the public
Would be Matt,
behind the
Louis,
scenes.
Matt, Louis, Kristen, and Samia. So we have.
I
4.
thought it was Vicky you were adding Vicky.
If she wants to be, but then we have already 5, so.
But
either way.
instead of Christina. So what I interpreted was Matt would be the chair and Kirsten would be there, Louis and Vicky.
And Samia.
That we can have 5. We can have more than 4. That's fine.
And Samia. If Samia is nodding her head, yes.
So the bottom line is, Vicky, would you like to be on it or do you not have time for it?
I don't have time for anything, but if you need me, I will be there.
Okay, why don't we do have 4, Matt, Louis, Samia, and Kristen. So we'll let you know, okay? So this way I don't want to put you under the gun here.
That's fine. Just
But
let me
thank you
know.
so much for offering that for sure. All right, so we're good. And that's it, right? Or do we have anything else?
You're
We
still going to
handled-
stay chair for practice?
What was the consensus on education and outreach?
Education and outreach, Ada would be the chair. Why are you interested? Ada, are you interested?
No, not right now, no.
But in the
No,
for
no.
meetings in the future, you said
No,
you'd be
not
available.
for what I'm,
Uh,
just 2 things happening.
Okay, so
Sorry.
I can remain the chair and then you can fill the vacant seat for now.
Right, do that for now, and then I'll transition into chair.
Perfect.
And then we can re-explore then the practice committee.
Later, yeah. For now, I'll stay chair of practice committee.
Does that work?
Yes.
Okay.
Yes.
Christine, I need you to continue chairing until we finish advanced practice.
I understand. I understand.
And I think it will be very interesting to see the impact of an OT assistant as the chair of the practice committee. That will be interesting.
You'd be great. But I will finish out this task.
Okay, thank you.
Legislative updates. Okay, perfect. So you have all the information?
Yes, I do.
Great. Thank you so much for everybody who's volunteering and helping us out. Moving on, do we have any public comments regarding agenda item number 23? Can we please open it up on WebEx for public comment?
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raise hand icon. Or if you're an audio only participant, you can raise your hand by pressing *3 on your device. All right, and it appears there are no requests for public comment at this time.
Do we only have the room till 12:30?
No, we can go until like 1.
Officially. Well, yesterday, because everybody attacked me, that lunch had to be at 12:30.
Depends on when they start.
Oh. Okay. Until, like, if it happens. Okay. All right. Thank you, moderator. Let's move on to agenda number 24, legislative update, review, discussion, and possible action regarding board positions on the following bills. Assembly Bill AB 277, Alanis, Behavioral Health Centers, Facilities and Programs Background Checks. Number 2 is Senate Bill SB 903, Padilla, Mental Health Professionals, Artificial Intelligence. And then B, discussion of chapter legislation, SB 497, Wiener, legally protected healthcare activity. I think, Austin, if you would like to.
Of course.
Thank you.
Thank you. So this is the legislative update table that comes to the meetings every quarter. It gets updated as bills get added and their status change. Since the last time the board took positions on bills, there have only been a couple that have been updated that need to be looked at. So the first one is Assembly Bill 277, Behavioral Health Centers, Facilities and Programs, Background Checks. If we move past the table to the next item in the materials, you can see a copy of the bill. Now, the board has seen this bill before and took a position of watch in June of 2025. However, since then, the bill has been amended, so it's just worthwhile to see if the board has an updated position. The change can be seen on page 2 of the copy of the bill, where the text has been stricken. So we can see here, for a behavioral health center facility or program shall undergo a background check pursuant to section 11105.3 of the penal, and then it previously said code, to identify and exclude a person who has been convicted of a crime involving a minor, and now simply says code. So we can have discussion before we take a position, but if the board is ready to either amend or keep their previous position, we can move forward.
I mean, I'm okay watching it unless, okay, we're gonna watch it.
Okay.
Thank you.
The other bill that has changed, or rather has, I don't think the board has seen this before, is Senate Bill 903. And this has to deal with mental health professionals and artificial intelligence. This is that bill pertaining to transparency. So this is immediately following 277. And this prevents a corporation or entity from providing, advertising, or otherwise offering therapy or psychotherapy, including through the use of internet-based artificial intelligence, unless the therapy or psychotherapy services are conducted by an individual who is a licensed professional. Additionally, prohibits a licensed professional from allowing AI to make independent therapeutic decisions or take other specified actions related to communications with clients. This would authorize the department, meaning the Department of Consumer Affairs, to investigate actual, alleged, or suspected violations of these provisions and impose civil penalties as prescribed. So this is something that further regulates the use of AI in healthcare professions.
I mean, I'm okay watching it since it's so new, but if any board members would like to proceed otherwise.
This is also something that the newly formed ad hoc committee could take a deeper look into and make a recommendation for at the next meeting.
I think what I would need is clarification on the limitations that are being indicated in the bill. So I think it would be good to maybe in that committee be able to more clearly outline what's happening.
Sure.
That would be helpful.
A watch for now then.
Yes. Are you taking notes, Erin?
All right, and that concludes our discussion of bills that are still on the docket for the legislature. However, we have some chaptered legislation that the board has not previously seen. This was not included on previous legislative updates because we weren't aware of it until it was chaptered. So our apologies on that. But this is Senate Bill 497, Legally Protected Healthcare Activity. Now, this is chaptered, so there's no need to take a position necessarily, but I did feel that it was important information for the board and members of the public to know. Uh, in effect, this bill makes it a violation of law for a California licensed healthcare professional to cooperate in the investigation conducted by another state to look into whether or not gender affirming healthcare was provided in the state of California to somebody. And again, no position needed on that, but the board hadn't seen this language or this bill before, so I just felt it was important to bring it to everyone's attention. And unless the board has any questions for me, that is all I have for the legislative update.
Any board comments on any of the legislation? Do we have any public comments? Can we please open it up on WebEx for public comment?
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raise hand icon. Or if you're an audio only participant, you can raise your hand by pressing *3 on your device. All right, and it appears there are no requests for public comment at this time.
Thank you so much. Moving on to agenda number 25, Executive Officers Report. Take it away.
Thank you very much. I'll make this brief, as has become the pattern lately, but I appreciate you guys sticking with me as I read through it. So, main points of interest on the report here would be our fiscal information as of fiscal month 6. Current year-to-date revenue earned by the board is $1,936,000, and current year-to-date expenditures plus encumbrances is $1,699,000. Included in the materials, we have 2 versions of the fund condition based off fiscal month 6. The first of those shows month in reserve under the current fee structure of the board. The second of the fund condition shows months in reserves projected, anticipating our fee increase that is expected to take place on July 1st of 2026. We also have a brief personnel update. The vacant position that existed in the administration and licensing unit of the board was filled just recently, and that was filled by a internal candidate at the board. So we do have now another staff vacancy, which we're putting together a recruitment package to fill as well. Technology updates regarding the Breeze platform. Main notable thing here is that we now have the ability to publish documents to an applicant. So if we need to upload a document that we want an applicant to see, rather than having to email it to them, it is also available to them in their Breeze account. Following that memo here, we can have we see a brief or a detailed breakdown of the revenue earned by the board. Following that, we have a more detailed breakdown of the expenditures of the board up to this point in time for the fiscal year. We can then see the fund conditions that I mentioned earlier. Again, this first one is under the board's current fee structure, and the second one is anticipating a July 1st effective fee increase date. Following the fund condition, we have some licensing statistics. This shows information for the number of transactions received and processed by the board in the last quarter. That's from October through December of 2025. Following that, we have some enforcement data. We can see complaints data received, investigations closed for the previous quarter, that same period of time, October 1st through December 31st, 2025. Similarly, we have more enforcement data. This has to deal with citations. This table lists all citations issued to occupational therapists over the last quarter, followed by citations issued to occupational therapy assistants over the last quarter. We then come to the cases pending at the Office of the Attorney General. These are anonymized, but you can see the status of all the pending cases. Some of these were set for yesterday's closed session, so their status is not quite up to the very minute, up to date, but they'll be updated by the next board meeting. And then we have the final decisions issued over the last quarter. These are not anonymized. These are public information, so you can see those here. And lastly, we have our list of licensees currently on probation. Are there any questions regarding the information contained in the report?
Any board members? Do any board members have any questions regarding the report? Do we have any questions or comments regarding the report in public? Can we please open it up on WebEx? Public comment?
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raise hand icon. Or if you're an audio only participant, you can raise your hand by pressing *3 on your device. All right, and it appears there are no requests for public comment at this time.
Thank you so much, moderator. Okay, and then the last agenda item is number 26, suggestions for future agenda items.
I have a question that might end up being one. Please help me remember the status of the language regarding the continuing education frequency for new, like the first time renewal.
For first time renewal?
Right.
The last time that was before the board was, I believe, June 2025 was the last time the board looked at it, 4161. So we have that approved, and we didn't bring that one back today. That didn't need another vote, so that's still going through the process, but it hasn't taken effect yet. So at present, first-time renewals do not require continuing education.
And so it's moving forward through the process, and do we recall offhand the date that it becomes in effect?
We don't have an anticipated effective date yet.
So it's part of the process.
Right.
Okay.
So the next major part in the process for that will be once our initial submission goes through to OAL, it'll get posted on the notice register, and there will be that 45-day comment period. And that's probably about the time we might have a better idea of a anticipated effective date.
Thank you.
And anything else? No? We go to public comment?
As Helen would say, it's always a good time.
Do we have any public comments to be added? Yeah, okay, let's do it.
Sammy Rafidi again. I just received this from a colleague this morning, and this colleague was wondering if something can be added to the Practice Act for people who are supervising doctoral capstone students to receive PDUs or continuing education as it is for those who supervise fieldwork students. So right now there's a potential for people who take fieldwork students to earn professional development units, but there's not a similar language for those who supervise doctoral capstone students.
I believe, and I'll double check on this, but I believe that was included in the 4161 language that was here last June.
Oh,
And I
okay.
think it makes provisions for earning PDUs for supervising doctoral capstone students.
Okay, great. So you
But
said,
if it's not, future agenda item, but I'm pretty sure it's on there.
Okay, did you say it was 4160?
4161.
4161, okay.
And you won't be able to find that online, but it'll be in the materials
the
from
notes.
that meeting.
Okay, and that was last June?
Yes.
Okay, I'll go back and look.
Okay.
Thank you.
Thank you.
Okay.
Well, you can take a pause. Thank you, Samia. Do do we have any public comments on WebEx?
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raise hand icon, or if you're an audio only participant, you can raise your hand by pressing *3 on your device. All right, and it appears there are no requests for public comment at this time.
We can deal with that after this.
Thank you so much, moderator. This is after this. Okay, so I mean, at this point, we're ready to adjourn. Thank you so much for everybody in attendance, again, DCA for hosting us. Karina, you did such a great job supporting us, and our lovely attorney, Helen. Thank you, Austin, for all your hard work, and all the board members for always delivering and being here. And of course, our reg attorney, DP. Thank you so much for all your knowledge and all your help and supporting us in making things happen. So we really appreciate you. All right, thank you all. Have a wonderful weekend, and it's 12:36 and meeting is adjourned.
Thank you, everyone. Goodbye.